Assalamu alaikum. Good afternoon. So I'm going to talk today about light. It's not literal, not philosophical light. It's a light that you should follow in glaucoma treatment. And I mean this light. These are the studies that give us the landmark of how we diagnose and treat glaucoma over the years. These are the base of all protocols, the European, American, and even in KKASH, we follow them. And light has made it to the list in 2019. And light is a study that compares between selective laser trabeculoplasty versus eye drop as a first line of treatment of ocular hypertension and primary open-angle glaucoma. We usually, when the patient first diagnosed with the glaucoma, we usually go with we usually prescribe medication. This is what we always use, and we always think which medication is the best with the prostaglandin, changing the color of the eye. We've seen many patients complaining of the darkness. There is also the periorbital fog resorption of a certain age now, 50 and 60 years, still considered younger generation, and they're already having not younger, still young, they are already having sunken eyes, and when we give them prostaglandin, we exacerbate this. Beta blocker with their comorbidity, especially in systemic patients with systemic diseases. Alpha agonists carry a very high rate of allergy, up to 25 recorded allergy. And carbonic anhydrase inhibitor with their sulfonamide structure that can cause topical and systemic immune reactions. They can damage the cornea, corneal epithelium, and plus for the glaucoma medication, usually there is non-compliance. And many studies have reported that there is a non-compliance rate of between 24 and 80%. It depends on how they calculated the non-compliance rate. And in one published study that 50% of the patient who started on glaucoma medication, they stopped their medication in 6 months. And we're facing it in our clinic, 20 to 30% of our patients that they didn't understand that medication should be lifelong. They didn't get how to refill or how to use it. And as for SLT, SLT started in 1995 and got the American FDA approval in 2001. Okay, it's safe, it's effective. Many researchers have published the result between the difference between the effect of SLT and prostaglandin. But usually all the patients that had SLT, they were already on medication, and we'll describe later how this affects, because having the medication for years will change your trabecular meshwork, especially if it is preserved with back. So SLT will have less favorable outcome when you use it on a patient who already been on medication versus a treatment-naive eye. So we know that SLT works because it's made improvement of the ALT, and ALT we know it works. There was the advanced glaucoma treatment study that showed us that ALT giving a good result, but ALT had the problem with being very difficult to perform. Okay, it needed experience, and plus we couldn't repeat it because it was damaging for the trabecular meshwork. As SLT, very easy. It's a safe, high safety threshold that in the UK they are thinking of letting the optometrists train them to do the SLT in their clinics without the need of an ophthalmologist. And the plus, because it doesn't damage the trabecular meshwork, it can be repeated several times. And this is a publication in 2021 from UK where they studied the long-term result of SLT, and they found that success rate was 98% in first year, 89% in 5 years, and 72% in 10 years. That is medication-free. And they saw that most of the failures were in 3 years, and that the median time for retreatment 81 months, almost 7 years. So some of the patient has just once, and they stayed stable for 10 years. And this is we have noticed in several of our patients in KKASH. Although KKASH is not a very good example of SLT, because most of the patients that come to us, they are already having comorbidity, they have failed trabecular surgery. Our our acceptance, eligibility, patient in KKH is very high, very advanced, severe disease, so that's why SLT is not very good, but still many patients have done SLT since 10 years, 5 years, and still they are off medication. So they thought in Moorfield, actually they started, because when they reviewed their cases, they found out that they are only utilizing SLT 15% for 15% of the eligible patients, new patients. So they thought of studying the difference between SLT and drops as a first line of glaucoma management. And they studied three outcomes. The first outcome, the effect on quality of life between drops and SLT. The second would be how much effect, safety and stability and control of glaucoma. And third one is also an important issue in the world, the economics of SLT versus drops, which is economically more cost effective. Okay, so they started the study in 2012 and they recruited patients up until 2014. It's unmasked because we are studying the quality of life for the patient without the drops versus patient with drops. But it was totally randomized. And they screened 16,000 patients, okay, and the patients who were eligible for the study, they are ocular eye hypertension, primary open-angle glaucoma, who were eligible for glaucoma management according to their NICE protocol, which is the National Institute Healthcare Healthcare Excellence. Sorry, and this is derived from the American Academy of Ophthalmology recommendation for glaucoma management and the European guideline. So the patient should be knowing English very well, okay, at least to understand the questionnaire, because there were a lot of questionnaire over the years. And second, they don't have any contraindication for SLT. The contraindications for SLT is that they have uveitis, that they have comorbidity with rubiosis, uveitis, rubiosis, and patient cannot sit for the SLT on the machine, or there were opacity that preclude the trabecular meshwork, or the patient cannot tolerate the treatments by sitting or clear. Okay, and of course they removed pregnant ladies because when they escalate to trabeculectomy, after that they cannot use the mitomycin. So other than all patients are accepted, and they also excluded patients for the eye drop arm when they cannot put the drops. And out of these patients, they randomized 718 patients who finished for 3 years, 3 to 9 analyzed in the SLT group, and 3 to 3 analyzed in the eye drop group. Actually, this study is still going on, and in 2019 they published the 3 years, and they are preparing to publish the 6 years result of the study. They only thought of randomizing between the two groups, like to make it equally the ocular hypertension and primary open-angle glaucoma. As for the severity, as for the presence of pseudo-exfoliation, corneal thickness, severity of the disease, intraocular pressure, they didn't randomize because then it would be very difficult, and it was carried out in 6 centers in the UK. So they only made ocular hypertension and primary open-angle glaucoma of equal numbers in the two groups. The rest is by chance. And if you can see these numbers, they are almost the same. Like I think there is a severe open-angle glaucoma is 6% in the SLT group, 5% in the drop group. Moderate, no, it's 12% in the eye drop and 10% in the SLT. They studied the quality of life questionnaire, okay, and as we can see, they are almost significant. Laser is the blue line and drops are the red line, and they are the same thing. There is no significant changes in the quality of life between the two groups. Glaucoma utility, they had almost the same with the laser doing better.
They're trying to do us dirty. happens.
And as for the glaucoma symptoms score, the higher the score is the better result, the less symptoms you have. So as you can see from day one in the participation, because the patient had laser that day, SLT, so they had more symptoms, they were worse in the laser group, but then after that, patient with the post-SLT has improved in their glaucoma symptoms, while patients on drops got worse with the usage of drops. And glaucoma quality of life, this is how much you are affected by your visual field defect and usage of glaucoma medication. And as we can see, both there is not much of significant, although in all the cases, laser did better than the drops. But with this, there is some improvement, maybe because the patient have started to live with their disability and move around. This is like measuring how much you are disabled in doing your daily life by the defect you have in your vision. So maybe it's improved because they started to get around their deficiencies. Okay, of course, the period of 3 years was not that much to show us that progression of glaucoma has affected the patient life. We need more years, that's why they are publishing the 6-year result to see if there was a changes. Plus, these patients were followed up closely. They were having regular clinic visit, regular visual fields. So, the result of is it effective? The effectiveness of this is the drops and this is the SLT group. So, how much pressure at target in the treatment group was 93% after 36 months, after 3 years. And in the SLT, 93% were at target. There was acceleration of treatment. Acceleration of treatment was measured not according to the physician that measuring. It usually was carried out when the patient is having either continuous 4 millimeter mercury above the target with some changes in his visual field or optic disc cupping, or when they are at target and they still have a progression of the disease. And this is usually was monitored by a masked person, and he will decide to accelerate, not the physician, not the patient. So almost acceleration of the treatment was masked process. So as we can see that acceleration happened more in the treatment, medical treatment group, 384 needed, an increase in medication or surgery. In the SLT group, it's 299. So in the surgery, trabeculectomy, only 11 patients in the drug group needed, okay, and 0 in SLT needed. So maybe that's because the patient were non-compliant, and that caused the acceleration of their disease, okay, and that was causes the high number of in trabeculectomy in the treatment group. And 7 of them have needed revision of their traps. And this supports the idea that we have, the hypothesis that we have, the chronic use of glaucoma treatment will damage later on trabeculectomy by inducing fibroblast activation. While in SLT we didn't need any surgery. Another thing that proven another hypothesis that we have, 25% of the treatment group needed phacoemulsification versus 13 of the patients in SLT group. We have a hypothesis that the use of glaucoma medication will accelerate present cataract in the eye. So maybe this is also again proved in the patient with the drops. As for the medication, total number of SLT was done. 6 eyes in the treatment group needed SLT because they asked for SLT when they needed to accelerate their medication. So this comparison is a bit wrong in between the drops that we needed. So when we started the SLT, we should start this one with 1 because we started in the medication group, all the patients had drops, while in the SLT groups we don't have drops. This is the idea behind the study. So we have to compare, like when we added another drop, in the drop group, we had to add another drop in 18%, while in SLT we needed to add drop only in 12% of the patient. third drop, in the drop group 6%, in SLT 4%. So still with SLT, even adding medication is less. Actually, the protocol, NICE protocol, is not to be given more than 3 drops for the patient, not more than 5 drops per day. So 3 medication and 5 drops per day. This is the maximum accepted for them. And then after that, they should go for surgery, or they should offer SLT, but here sometimes the patient will refuse and they might go to a 4th drop. Actually, we know that when we add more medication, it's not as effective as when we use the first medication. Okay, so adding another one, and there was a study between having prostaglandin alone and having prostaglandin timolol combination, and the difference between both medication was 1 to 2 millimeter mercury only reduction in intraocular pressure. So adding more medication might not benefit the intraocular pressure, only reducing compliance for the patient and worsening their condition. So as for the safety of the disease, safety of the intervention, there was a lot of adverse effects, but they are all topical, non-significant, like many of the patients. With the medication, they complained of irritation, blurring of vision, watery eyes, and it was almost 71%, the whole thing. 73% in SLT, and this is after the SLT, because the day of the SLT and after 3-4 days, patient will have redness, will have some uveitis, very mild, usually just a flare, irritation, dry eye, that disappears within a week or 2. The other thing, like there were spikes, IOP spikes in SLT in 1.7% of the patient, and these patients with the IOP spike, they denied another SLT to be done. So when they needed escalation of the treatment, they pushed them to the medication, not repeating the SLT. So SLT is as effective as drops, maybe better. Okay, SLT is safe as drop and safer because SLT is only adverse effect that happened during the first week, while medication will continue with the patient for life. Now we come for the cost, the third thing that they measure. And the cost for SLT was less than glaucoma medication. And there was around 500 something pound less cost for patient when they did SLT. Okay. They are also explaining that in SLT, they made the patient come after 2 weeks for follow-up, and then after this study, after doing this number of patients, they decided to omit this regime because no need, patient will be okay after SLT, so we'll give him just a regular follow-up. Another thing, there was, as we said, in the life quality, there was not a significant difference, but still laser did better, and the change was 0.01 change between the high quality record between patient and drop. So when it was corrected for the cost and for the lifespan of the patient, the quality year in life, they found out that there will be saving per patient between 20 to 30,000 pounds. Okay, and this is didn't include measuring the, for example, patient cannot put the drops, so he needed somebody in the house, a maid or a nurse to come and put the drops for them. This is not included other things that patient go through with the medication. Just to find, okay, maybe you say we are in a government hospital, we don't care for the cost. Okay, even whatever the budget will be, it wouldn't be unlimited budget. Okay, so we need to take care of money also, expenses, okay, because whatever you don't spend here, you can put it in another like project or program. So this is just to show you how much some of the countries are paying for glaucoma management. So in UK, in 1999, they were spending per year for a patient $1,300. 61 of them was for medication. And now they have 11,000 patients per year. In Australia in 2005, they said that they spent almost $2 billion for glaucoma management. In US, they are spending annually also almost $2 billion, okay? And there is $1.5 billion that are spent on disability, social securities. So if you treat the patient very early, if you control glaucoma very early, you get rid of disability, the social security, and plus you utilize the money for the medication and another thing. In Canada, they calculated in 2006 how much will save us if we do SLT in the Canadian system. So if you do SLT every 2 years, there will be saving when the patient is on one medication, $200-something cumulative cost saving in 6 years, and up to $2,900 if you have medication stop the patient stop 3 medication. And 3, if you repeat SLT in every 3 years, like the cost will be saving will be doubled. In Australia also they measured how much they are saving by doing SLT for the patient, and it was $2.5 for every $1 you spend on SLT versus 2.5 on medication. Plus there is, if you do SLT, you don't need to follow up the patient regularly by ophthalmologist, because once he's controlled, you just need to check his IOP. He can go to optometry clinic, because most of these government, they mandate that the patient go to an ophthalmologist to have a prescription, because medication are dangerous, so need to be prescribed by a physician. And that's why you still control more the disease, and you spend less if you do SLT. This is from USA, how much the cost effectiveness. Sorry, don't be mad, that mix are very popular now, but they are very expensive. So they calculated how many drops they stopped for the patient after every procedure, and how much there was like expenses more. So for the SLT, they spent $570. For CBC and trabeculectomy, $2,400, and this also includes all the staff that you use to treat the patient, hospital admission, OR, occupation, okay? And mix varied between $3,000 to $7,000, being the least is trabectome. It costs $500 per 1 millimeter mercury reduction in pressure. And if you say that mix is better than SLT, in 2012 in Germany, they published a study what they did for the patient trial, SLT versus trabectome versus iStent. And they measured in 3 years what they were. The pressure reduction was almost the same between all cases, 31, 31, and 29. And as for medication reduction, in SLT, there was a medication reduction. The first 2, there was none. And both had a moderate survival rate, with being the best is SLT, with 93%, trabectome and iStent was in the 70s. Even trabeculectomy, that is the gold standard, we know that it's not 100% successful. This was part of the primary trabeculectomy versus Bartlett study, and they found that the absolute success was 93, 58, and 53% in 6 months, 12 months, and 18 months. And absolute and qualified success was 76% in 2 years. So SLT is very safe, it's very easy, it's just a clinic visit. It will be done in a few minutes for the patient, and the patient will go home free. But there is a problem with a patient being put on medication, and then we'll do the SLT after that, because as we said, there is damaged cornea. And it was published several times before, when they comparing the SLT with the prostaglandins, that most of the patients will be already on medication, some of them will be medication naive, and they found that medication naive will have a reduction of intraocular pressure very good. And in light study, they were aiming to reduction of pressure 20 to 30%, okay? And they treated even the severe cases. So even their justification, they are telling, like before we used to say SLT is not for severe cases, And it's not because of the cases is severe, it's because the patient was on medication for several years, then he had his SLT. So it's better to do SLT as a primary treatment, better than putting the patient on drugs. If during life, when they had to like postpone SLT for a while, they didn't allow it more than a month, okay? And during this month, they gave the patient diamonds, okay? So that they will not damage any of his trabecular meshwork. SLT is very good, but it's not for all glaucomas. So like primary congenital glaucoma, you cannot do SLT, it's not effective. And even in juvenile open-angle glaucoma, that they have angular dysgenesis, okay, and I think here in Saudi there are a lot of them related to primary congenital glaucoma, and there were publications that they are linked to CYP1B1 mutation, so it's not recommended to do it. There is a publication that showed when you have angle dysgenesis, there is no effect of SLT. Uveitis patient is also not a good idea to have for them SLT. It's almost contraindication. Some people do it, but all the publications showed it's not. There is no result. But steroid responder, they respond very well for SLT. Angle closure glaucoma, secondary angle closure, is a no-no because you don't have normal trabecular meshwork to treat. As for the primary angle closure glaucoma, if you have an open angle for 180 degree or more, go ahead and treat it, and the result is the same as primary open angle glaucoma. So, any glaucoma fellows here? I would like somebody to answer me if you have SLT and you need to do surgery for me. Looking to the result of SLT, which surgery would you like to do for me? DS, which makes, no, anybody? Okay, so SLT is treating the trabecular meshwork, and this is Dr. Singh in one of the ESCARS meeting. He suggested that do SLT as a test for your mix, for future mix. So if you have a good result with SLT, then you do an angle-based mix, like I-stand, trabectome, Cahook double plate, okay? If you have a bad result with SLT, means your glaucoma pathology is not in the trabecular meshwork, it's behind it. So it's better to go with the DS or other like that overcome the... okay, so, and another thing also, another suggestion was, and we were following it up here in Kesh before, because we don't know what's the pathology behind the glaucoma, where is the injury, so they were suggesting that doing two mix, like for example, do ECP and put an I-stand, so that you hit two areas of the causes of the glaucoma. Okay, when you saw the prices for mix and for it's very expensive. We were doing here actually, Dr. Samir Ahmed, if people remember him, what we were doing SLT for the patient, stopping medication, doing SLT for the patient, and then in few weeks, 2 to 3 weeks, we were doing phaco ECP. So we hit the secretion and we'll open the trabecular meshwork with SLT. And patients were doing fine after the surgery without drop, or like do just a phaco in mild glaucoma and wait for a while and then do SLT to keep the patient off medication. But again, the best thing to do SLT is as a primary procedure, as a first step in glaucoma management. Thank you very much.